the building anticipation, you know?
It looks like we're back to the number of people who had joined earlier, if you'd like to restart.
Perfect. The only one we're waiting for is Mary Beth, who has the story we're going to go into next. This will also test our editing skills when we have to work through the video. So this will be impressive work amongst everyone.
I'm so sorry. Could you hear me?
Yep, Mary Beth, you're good.
Oh my
Everybody
gosh.
got kicked off. No
Oh
worries.
my God. I just had a panic attack.
It's okay. Again, in essence of this presentation, let's recenter. We'll all take a breath. Right?
Okay.
Psychologically safe space as we present to. We are going to start it over. We are at the point where we are transitioning to our story. Again, if you're all here, we're for escalating care concerns in the clinical setting to help support this. And I was handing it over to Mary Beth O'Malley to share a story, and that will then lead into our panel discussion, followed up by a presentation by Julie Uspel. So Mary Beth, you're all good. Take it away.
All right. Great. Thanks, everybody. Good morning, and I'm so glad to be here to share a story with you. This is a 24-year-old woman with a history of cerebral palsy. She's nonverbal at baseline, but was able to communicate through expressions. She had quadriplegia, epilepsy, gastroparesis. She also had a G-tube in place and was TPN dependent. She had a neurogenic bladder with a suprapubic catheter, and she also had asthma. She presented with fever and vomiting and was found to have positive blood cultures, and there was a concern for a staph epi bacteremia. Her parents are her primary care providers and were with the patient continuously. They were able to alert staff to subtle changes in their daughter's clinical presentation because they know her best, and they were so helpful during her hospital stay. Her medications were administered via her G-tube, but needed to be given slowly to avoid coughing and potential vomiting. During this hospital stay, the patient had several episodes where she vomited, which resulted in transient desaturation. These events would require suctioning, but the patient would quickly recover. When nursing brought this concern to the team, nursing was told that it was the patient one. One morning, after receiving her medications, she projectile vomited a large amount of fluid and subsequently desaturated to 60% and ultimately became cyanotic. She was observed not to be breathing for a very brief period of time, despite the aggressive suctioning, and appeared to be in obvious distress. An RRT was initially called, then escalated to anesthesia when her oxygen saturation failed to increase despite the positioning, suctioning, oxygen therapy, and the appearance of apnea. Respiratory arrived to the unit, and within a few minutes, the patient's oxygen level increased, her pallor improved, and she was finally able to breathe and cough. Once the patient was stabilized, a plan was created for ongoing frequent rounding with additional respiratory support out of an abundance of caution. After the event, nursing was told by the provider team that the RRT could have been avoided if they had been notified first. But nursing felt as though the RRT call was appropriate given the urgency of the situation. So now I'm going to hand it off to Eliza. Thank you.
Mary Beth, thank you so much for sharing that story. I'm actually wondering if for the roundtable discussion, we can put the slides down so that we can see folks' faces a little bit more perfect. So I'm Eliza Narva. I'm really excited to have this discussion with our panelists. It takes a lot of vulnerability to share stories about practice. And I also just want to say quickly, obviously, these are stories about real people involving real patients. I always think it's helpful to sort of center the humanity of all of these folks as we're telling these stories and sort of sharing our experiences. These stories are about what happens when there's not psychological safety. Can you hear me? Okay, yeah. I cut out for a sec. Perfect. psychological safety, right? It's a shared belief that it's okay to ask questions, that it's okay to take risks, that it's okay to speak up about mistakes without bad consequences. And so as we're talking through this, I want everyone to start to think about what would have happened in these situations if there had been psychological safety. So we have a couple of questions. Really excited for our panelists to share their experiences, and hopefully we can have a little bit of a conversation. And so, Laura, I see you. I'm gonna kick this first question to you, if you don't mind. I'm wondering if you can describe a time when you didn't raise concerns that you had about an aspect of clinical care because you felt there was a lack of psychological safety, either from someone on the team or just in the clinical environment.
Thanks so much, Eliza. And thank you everyone for having me. I'm looking forward to speaking. And as Eliza said, it is a little, being vulnerable, sharing a story, but I think it's something that we can all learn from. So I'm going to share a time when I was a newer nurse. I was about 2 years into my practice and was actually orienting a nurse. And on the unit that I was on, we would have generally a 3-patient assignment, 2 patients, generally more complex, and then one like a straightforward patient. My straightforward patient was a pre-op patient awaiting surgery and just had to get like workup testing done. The patient was completely independent, meaning she could walk around the room independently. She was, feeding herself, walking the halls herself, completely alert and oriented, times 4. So she left the unit to go for a TE, and returned back and was absolutely not herself. She was diaphoretic. She was extremely agitated and was complaining of this upper abdominal pain. And I was, about 2 years into my practice, but so heavily focused on cardiac, that I was just like so confused. I was like, I don't understand what's going on. Like nothing in her history kind of painted the picture of like what could have happened. And the TE, of course, goes down the esophagus, so not even close to like the abdomen area. So I let the provider know, and the provider's response was just give pain meds. And that made me kind of uncomfortable because I was like, I don't feel that that's addressing like what is happening. Like this is a change. Like the woman does not look like herself right now. However, I gave the pain meds and I just like kind of waited it out. However, the patient continued to decompensate essentially. She started to get severely agitated. She was kind of like thrashing in bed and moaning, and then started to kind of like lose consciousness a bit. She didn't like completely, go unresponsive by any means, but she was like really just sort of floaty and not really herself. Um, and so I called the provider in again, and I still just, like, felt like something was, like, really going on, like, and I didn't know what it was, and I was so, like, kind of upset with myself, and the provider was just kind of like it seemed like they were unsure as well, so also kind of just, like, diminishing my concerns, like, "It's fine, it's probably just from the procedure," which, again, the TE is so standard, like, I had never seen a patient come back from that, and have this kind of like they receive like moderate sedation, like it's not something that they would look like this after the procedure. So she continued this carried on for almost 2 hours, and I remember at one point being in the room with a fellow nurse. He was actually like kind of the same experience level as myself, and he was helping me insert an IV, and the patient was at that point almost completely unresponsive. And the other nurse looks at me and goes, "Staff assist, like should we like call for help?" And I said no, because I felt that the team was just kept telling me like it's fine, it's fine, it's fine. It's just from the procedure. Um, Eventually my charge nurse kind of saw that I was like running around, and stepped in, and helped. And eventually the patient did end up getting transferred to the ICU. And of course, this is so long ago now. I've been a nurse for 8 to 9 years. I don't remember like what the outcome was. And I think also at the time, again, just so focused on my specialty that I didn't know what wasn't able to like really put the whole pieces of the picture together. But I reflect on that time a lot, because I didn't kind of feel like psychologically safe in that scenario to like speak up. Like I think of myself now in that scenario and how I would have kind of like sounded the alarms, maybe quite literally. um, and I really wish that like I had done it differently, but I think I learned a lot from that day about my resources. One, so I know different units kind of use the nursing clinical coordinators in different ways. The unit that I was on generally doesn't call like RRTs just because of the acuities that we have, but we still get the clinical coordinators in as like a second eye, and I think that would have been like really useful, especially since like I do believe it wasn't like a cardiac issue that was going on. Um, and also just like looping in my charge nurse, looping in other fellow nurses, and just really pushing that like this isn't okay. But I just didn't feel because I was just newer. And the provider that I was working with had so much experience. She wasn't even newer either, like years, like 15 plus years on that unit that I just didn't, I just kind of like kept saying, okay, 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 instead of really like pushing to advocate for the patient. So lots of lessons learned there. Thank you, everyone.
Thank you so much for sharing that story. It strikes me that not only was that scary and you must have felt really vulnerable, but the amount of blame that you're placing on yourself to not have handled that perfectly. And I can't remember the exact wording now, but your sense that you should have known everything rather than how we want people to feel, which is that we are working as a team with a lot of different people who with a lot of different information. Um, thanks for sharing that. It sounds like it must have been really challenging. Um, Devin, I want to switch to you quickly. I'm wondering if you can sort of answer the same question and provide an example of a time where you didn't feel like you could escalate a concern about clinical care, either because of the environment or because of some part of the clinical team.
Yeah, thank you. And hopefully everyone can hear me. Yeah, so I think this is a really interesting exercise because we have people from kind of all different realms of healthcare. And reflecting on this, I was at Penn as a resident, I'm at Penn as an attending, and the way I felt has been very different. And interestingly, and probably a good thing, it was pretty hard. Like as I was trying to rack my brain just from this year as an attending, what's happened, like when as attending have I not felt psychologically safe and supported to escalate care? And that was a lot harder because I think everyone wants the best care for their patients, but when you're an attending, you really kind of have this the buck stops with you mentality to patient safety. And if you're in when you're in the position to make that final call on what happens next, and you're kind of that determinant on the outcome, if you're really not certain in that moment, which you're often not, you escalate care. And I think, as an attending, that's one of the benefits is that I think that's improved. What I can think of, and I'll kind of talk a little bit with the second question about why I think this is. But sometimes I end up delaying escalating care, and I'll kind of, again, talk back to residency on why I think I have this reaction sometimes. But particularly in patients in this kind of gray zone where they're maybe not acutely decompensating, but there's somebody who either imminently could decompensate or, maybe just somebody who needs more resources and would benefit from that. So I think that all goes back to residency and potentially a bit of hidden curriculum that I'll talk about. But the case that I found, which kind of fits this a little bit, I had a GI bleed on the house staff service earlier this year. Had actually come in for a septic joint, had it drained at Presby as a leave of absence, came back. And then the hemoglobin was drifting post-procedure, which, she just had a procedure, so we weren't acutely concerned about. But then overnight, prior to the day of this event, she had developed acute GI bleeding, which was just completely unexpected, to be honest. And then that morning, kind of more frank GI bleeding, and her hemoglobin overnight had dropped a unit. The intern went to bedside and was handling the situation really well, was working on getting access. We called GI, they came to bedside. She dropped another unit in an hour. We got a repeat, and she was pretty much dropping a unit an hour at that point. With whole blood loss, I feel like you're also always like not quite seeing that full loss. But she was still hemodynamically stable, and GI, they were planning to do an emergent scope and taking her downstairs. But, in talking with nursing, nursing really wanted an escalation of care, which I didn't disagree with. I thought that this patient would benefit from the ICU because she could have needed massive transfusion protocol. We can only do 1 unit of blood at a time on the floor. And I initially advocated for it and had Nico involved, and they came to bedside. And I think just because of ICU space, and we see this a lot, we just got strongly discouraged from escalating this patient to the ICU, and we're encouraged to stabilize her on the floor. At which point, nursing was still being like, I think this is too much. Like, we can't really leave the room. We need to keep cycling blood pressures. She's losing a unit of blood an hour. And I kind of had to be like, well, this is what they want. And I think like where I feel psychologically unsafe in these situations, and this is what I see more as an attending, is that I don't always continue that discussion. Like, once somebody else tells me, especially as a junior attending, somebody who's only been attending for a year, if I have somebody years senior of me tell me, no, stabilize this on the floor, or this does not require escalation. And I've had this happen a lot at Cedar, where I've had patients I've been uncomfortable taking care of at Cedar because I'm there in person and know the resources. I kind of yield to that opinion because it's like, well, this person's more senior. Maybe this is just me being a new attending and being worried, and maybe I just need to calm down a little bit. But at the end of the day, this patient did need to go to the ICU, and the fact that I didn't kind of bring that up and just be like, hey, we just need to take her, and the fact that I wasn't just more firm, didn't affect her end all outcome, which was a good thing, but it did just kind of prolong her time on the floor. And I think if she'd just gone to the ICU, she would have gotten scoped in the ICU more imminently, rather than taking all these resources and time on the floor to stabilize somebody that I knew was going to be unsuccessful to stabilize. If they're losing at least a unit of blood an hour, like, I knew that was not going to be successful. So as an attending, that's been more my experience. And I'll talk a little bit more to kind of why sometimes I feel like we're a little hesitant as providers to call rapids on these, patients that I would refer to as in the gray zone, who are currently stable but may not be in the future.
Yeah, Devin, go ahead and keep talking. Tell us about that.
Yeah, this kind of goes on the second question. So
That's okay.
yeah, so I feel like, when we talk about psychological safety, like I said, as an attending, I have felt much more psychologically safe. In residency, it was different. And I think, in residency, when you're able to avoid calling a rapid, because we refer, you're just like, okay, good, you were able to avoid calling that rapid. It's viewed as a win if you can stabilize the patient, if you can triage them quietly to the ICU without calling a rapid. That's a good thing, and that's encouraged. And like, not that I think we shouldn't be doing those things and acting quickly and stabilizing patients, but I think there's been some hesitancy for those patients who end up in this kind of, again, gray zone, where we could just really benefit from having those resources and more people involved. And I know as an intern, and this is kind of potentially speaking to some aspect, I think, of hidden curriculum that is not unique to Penn. I've heard seniors say multiple times, when I went to rapids at bedside, that, oh, they shouldn't have called that rapid. And I think when you hear that and it sinks in, you're like, well, I want to impress my senior. So if I am advocating to call a rapid, that better be a real rapid, right? Like, that better be a rapid that's worth it. And that really matters, because they're evaluating you at the end of the day. And you don't want to be that intern that's like, always wanting to call rapids on patients that your senior views as otherwise stable. So, and I think, like, kind of thinking even just about the language we use, I never have heard someone say, at least from the provider side, oh, it would be beneficial to call a rapid on this patient. What I tend to hear is, I need to call a rapid, or I have to call a rapid. And that to me just reads more obligatory than patient care forward, which was kind of interesting to reflect on. So, I think as a resident, there were a lot of moments, and I tried to think back to some specific cases, and I honestly think there were so many cases where I felt not supported in calling for an escalation of care. It was just more the emotions, that kind of came around that. And yeah, I saw that comment come up, like that is viewed as a failure. Like it's your, if you're the intern for this patient, and maybe you should have caught this 2 hours ago, like that's your failure. So now try and fix it without calling the rapid. So I think that's a lot of why there's maybe sometimes some hesitancy.
It strikes me what a tremendous amount of pressure that is for a clinical learner to feel like there are existing resources for help, but you're not supposed to call them. You're not supposed to engage them. It's really interesting to hear about your perspective now as an attending. I think pretty beneficial to hear those different perspectives. Thank you for sharing that. I want to pivot now to Lovisa to hear your story. Tell us a story when you didn't feel like you could escalate your concerns, either because of a clinical factor, a person, or something in the environment.
All right, thank you so much. And I was just going to say, Devin, I completely feel the same way that you do. Like I can echo a lot of what you just said. As someone who's almost completed my training, I think when I was reflecting on these questions, I think a lot of there's been a lot of change from when I was like more of a junior resident and an intern to now being more senior and feeling more comfortable and having a harder time kind of thinking like of an answer to this question because now I have more comfort and like feel more able to escalate than I did when I was more junior. So I really feel like that was a very good point that you made. So I wanted to bring up a question or a story from when I was a junior neurology resident. And we had a patient who was on our stroke service admitted. So this is a little bit more of a slow burn, but essentially this happens very frequently. We're on rounds discussing a patient, and there's been like a long discussion about this patient about like whether we should essentially intervene on one of their carotids, because if they have a stroke on the same side as a stenosed carotid, then the guidelines say that you should intervene and stent or do a CEA on that side. And that's like a strong recommendation to do that. Oftentimes we want to make sure that there's no other reason that the patient had a stroke before intervening, because it is not, it's not harmful to do an intervention as well. And this patient in particular had a lot of like medical comorbidities. So we were weighing it very carefully to decide, like, should we recommend doing this kind of intervention or not? Ultimately, based on a lot of the patient factors, I felt very strongly that we should definitely intervene on the carotid. And some of the more senior members of my team didn't feel the same way. And I felt like, there wasn't a real reason that I was given that wasn't being recommended. They were just like, they're really sick. They don't take, like, they're an active smoker, like they don't take good care of themselves. Like I think there were a lot of patient factors that were maybe playing into the decision, which made me a bit uncomfortable, honestly, because I don't think that should be that those factors should really play into like our recommendation. And so ultimately the patient didn't end up getting the procedure and then had a recurrent stroke on that side. And I remember that because I was like very upset that I hadn't pushed harder for maybe doing an intervention. And of course, like you can't always predict the future. So like it was hard in that moment to know, like, should I push harder? Should I not? And that's the thing that happens a lot on rounds when you're a junior member, is that you might feel like you're making the right decision, but you're talking to a lot of people who are more experienced than you. And so you give a lot of deference. And I think that's part of like the culture of training in medicine, is that you have to kind of respect people's seniority, but at what point is it okay to also kind of jump out of line and say, actually, I think this isn't safe or correct?
Again, just thinking about how much pressure that is on sort of the youngest learners in the group. Um, I appreciate that story. And also, I'm just reflecting on how much sort of the emotional toll of being in this situation and feeling like you're not able to do the thing that you think you should do. That is moral distress, right? So we're sort of burning through our panel time. I want to make sure, Laura, that I get back to you. And I'm wondering if you want to talk about sort of what was it about the team or the team leader or the environment that made it so hard to speak up? And then as a second part, if you have thoughts about what would have made it easier.
Yeah, thanks, Eliza. So I think a huge piece in my story was being a newer nurse, and I know 2 years, especially now in like our high turnover environment, that doesn't that sounds like a bit of a longer time. But then that's not how I felt in my practice, and I think just kind of that like respecting your seniors, respecting those who have been there a long time and what they're saying, kind of similar to Louisa and Devin's stories of like, okay, if others are telling you like it's fine, I should believe that it's fine. And I think nurses oftentimes we say like, hey, we're with this patient for 12 hours, like we kind of know them like inside and out, like you get that like gut feeling, which I think like we talk about that gut feeling a lot in healthcare in general. And you just know that like something's not right. But I think being newer and being in an environment where it was like, okay, well, if someone above you is saying it's okay, then I should believe that it's okay. I didn't just like feel safe to kind of escalate that. um I will say, as I kind of grew within my practice, I felt a lot more comfortable to be able to like raise my concerns, and especially shifting from like a bedside nurse to like a leadership position focused on clinical aspects of care so much that I am now that one that's kind of like advocating for nurses if they have concerns for their patients, or sort of like bringing things to the provider. So like I'm now kind of that like bridge. And I think we've done actually a really good job over the years at shifting that culture just a little bit. I think it's forever going to be there in healthcare, unfortunately, but like I think from my perspective, we have done some work, especially like on orientation with those nurses, kind of like giving them the confidence to push, explaining that gut feeling, going over who your resources are, going over your like your clinical like chain of command. I think that's like a big thing that sometimes gets lost. Like, okay, if even say like my provider or my charge nurse are saying like this is okay, but I'm still like this is not okay, like where do I go from here? Like like you shouldn't feel like stuck. And I think too, a big piece to this is kind of like building interdisciplinary relationships. I did in some of my like coursework for graduate school, did some like literature reviews on just kind of building relationships in that sense. And a lot of it supported doing things kind of like outside of the clinical setting. And I'm not saying like, oh, okay, let's go out for coffee or whatever it might be, although that might be great. We all don't have time for that. But just like working on projects, like the providers and nurses like working together on something that's not just like taking care of that patient. And it really helps like build relationships. And I think that's like a big opportunity for us to be able to just kind of like grow. It's not an easy lift, that's for sure. But I think it's something to like look to. And then we're also doing some in our service line currently with help of our unit council chairs and the assistant nurse manager and on HVICU, Chris Klein and Amanda Lair. And then PDS of doing like kind of like a role play scenarios on the CUS framework. And I think it's been really nice. So like for example, the the example might be the nurse was taking care of a patient, the patient had a desaturation, the provider was kind of like, oh no, it's fine kind of thing. And like, how would you have that conversation? So it's like one of our unit council chairs kind of doing that scenario with a fellow nurse so they can like practice how that would be. Using your words like concerned, uncomfortable, it's a safety issue, like practicing like how to do that. And I think it was a great opportunity to just take like the cost knowledge link just like a little bit of a step further. And I think we could kind of use that in the future too, just like that same, we're calling it like CUS framework, that same framework to do that like role play, or we're calling it like low level simulation kind of thing, to continue to like increase that confidence with all interdisciplinary team members.
That's so important to actually practice those skills in the clinical
Yes.
setting in an interdisciplinary cohort. I think that's really interesting and very promising. And I also think a point that you made a little bit is, we're leaders at every level, right? We want folks who are coming into healthcare to feel like from day one they have some autonomy, they have the ability to make decisions, they have the ability to also ask for help, right? That is part of being a leader, is asking for help when you need it. So we have a few minutes left. Lovisa, I want to go to you with this same question of, what was it about that team leader or the team in general or the environment that made it difficult to speak up? And what do you think would have made it easier?
So I want to echo like a lot of what Devin had said earlier, because I think that with experience, it's easier to speak up. And I know Laura also touched on this, like it's easier to speak up because you kind of feel more confident in your assessment of the situation. And another thing is like just, and I don't know how one fixes this, but just the culture of medical training is very hierarchical and can really run counter to like a culture of safety, because it's not just a Penn Medicine thing, it's like in every place you train, is that we have a very defined structure of like who has seniority and who doesn't, and I think that can often run counter to our efforts to kind of create a safe environment for patients, because that's just how it's always been, unfortunately. And I would love if we had a way to fix that. But and then another thought that I had, especially from a resident's perspective, is oftentimes escalating is like there's a lack of time that you just are so busy. And so if you're gonna harp on one issue over and over, like, and it's not going to be heard, like, why do it at all? Can be like a mentality that a lot of trainees get, especially when it comes to safety issues. Like they'll, essentially say, well, I brought this up one time, nothing changed. I don't have the energy or the time to continue to bring this up. And I can say that I've definitely heard that from multiple of my co-residents, my co-trainees. So I think that is a big barrier when it comes to escalating things from a resident perspective.
Yeah, that makes a lot of sense. Everyone's time is so limited, right? We're so compressed. Thank you for sharing, both of you. Devin, I'm wondering if you're still with us, if you have any final thoughts.
Yeah, I mean, quickly, I think there would have been another question just kind of about how we kind of change some of this. And, it's interesting to me because kind of hearing everybody speak, I feel like there's a theme that junior learners or junior people in general just like don't feel like they have the support or the voice to speak up.
Yeah.
And I mean, that seems, especially when we talk about like our interns on medicine, like that seems exactly the opposite of the way that it should be, because it's kind of like if you're just learning and you're worried about somebody and the intern by far, I mean, when I'm an attending now, I'm seeing all 16 patients, all 18 patients. I get a very little time with them, but the intern's going to bedside throughout the day, and you're the one who's kind of repeatedly seeing that person. So the fact that that person who has the most touch points with the patient feels, scared to escalate care, if it's being discouraged from other members of the team, that's concerning to me. And I think that's something, it's a cultural shift that I think we need to make. And I think as far as, interns, I will say that, like, for us, like, we really don't get any rapid response training. It's not like you ever get formal training as an intern about, like, how to run a rapid response and who's involved. And that really never happened. It was just kind of more, you suddenly find yourself going to rapid responses and you learn from what you see. And it's really then dependent on what you see and who's running the rapid. And, I remember when I was an intern in 2020 when COVID was around, and I remember most rapids were extraordinarily chaotic during COVID, because, like, anytime somebody, like, had an escalation, everybody was putting on PPE. There was no family there. Like, people, I think, were really tired, a little bit more stressed than usual. So I remember just coming out of intern year, and I was like, okay, all rapids are very chaotic. I don't know, like, I want to try and avoid doing that if possible. And kind of later, it wasn't until much later I was like, oh, rapids can happen very smoothly, and be really beneficial. So I think it would be really good just for, like, more training, and even, like, interdisciplinary training, like with like debriefing, like, halfway through an intern's first year, like between, nursing, the clinical coordinators, interns, just to talk through these scenarios and see kind of all those different opinions, because I feel like you don't get that as much until later. And I just think we need to kind of dismantle some of this kind of, again, like, I refer to this hidden curriculum here, that calling a rapid's a failure, or that, you should only call it if you absolutely have to. I think we kind of need to be like, if you feel like you need more resources, you should feel free to, escalate and use those resources. And, if you don't need security and pharmacy, you can turn them away. If you called the rapid for pharmacy, you can tell pharmacy to stay and turn other people away. But I think there's just so many different flavors of rapid, other than the, like, actual total decompensation, and reasons to escalate those resources. So I think that would be a really good thing to provide more education on.
That is a great point, and I think a good final point for our panel. Thank you all for sharing your stories and being vulnerable. It is really always helpful to learn from people's personal experiences. So with that, I am going to turn this over to Julie Uspel, who is going to talk a little bit more about psychological safety.
Perfect. Thank you so much, Eliza, and thank you so much to our panelists for sharing stories and insights this morning. Again, my name is Julie Uspel. I am our Medical Director for Quality and Safety in the HUPED. And this morning, I'm excited to talk about psychological safety, which is truly the foundation for any high reliability organization. Now, Eliza had defined this earlier for us, but again, psychological safety is defined as feeling safe to take interpersonal risks, to speak up, to disagree with others' opinions, and to voice concerns, all without fear of negative consequences. On the next slide, we see that Amy Edmondson, who is a leader in this space and a pioneer in psychological safety, has defined this as a climate in which people feel comfortable expressing and being themselves, where they feel comfortable sharing concerns and mistakes without fear of embarrassment or retribution, where they are confident they won't be humiliated, ignored, or blamed, and they know they can ask questions when they're unsure. They trust and respect colleagues. We know that this type of environment where team members feel valued, where they're not afraid to speak up, where they can ask questions, they can voice dissent in a productive and professional way, creates a space that allows for better collaboration and higher functioning teams. We all come to work every day wanting to do our best to take excellent care of patients, but unless we feel psychologically safe, we'll never reach our full potential individually or collectively. We need to feel empowered to bring our best and most authentic selves to work. Next slide. And ultimately, at the heart of all of this is making patient care safer. And so creating environments where all team members feel safe to speak up on behalf of patient care is essential. So now that we know what psychological safety is, it's equally important to talk about what psychological safety is not. Psychological safety is not being kind or nice or going along with somebody else or being agreeable for the sake of being agreeable. It doesn't mean that everyone will agree with you or that you're going to get unequivocal praise or unconditional support or guaranteed ease or comfort. In fact, it's quite the opposite. Psychological safety is about fostering an environment where productive disagreement and the ability to speak candidly and with free exchange of ideas. Similarly, psychological safety does not mean immunity from consequences or that you won't fail or that you're automatically going to get great reviews. It just means that when you speak up, that you can use your voice and it won't negatively impact you or have negative consequences for you. In the Fearless organization, Amy Edmondson argues that there's a sweet spot for organizations and teams where they have high psychological safety and high standards. And it's in this space where psychological safety is high and the standards are high that teams really work well together. They innovate, they collaborate, they perform really well. For teams that have high psychological safety but low standards, they tend to stagnate in a comfort zone. And for those teams with low psychological safety, they either are apathetic or highly anxious. Next slide, please. This all makes sense, right? We want this type of environment. And yet this is a relatively new concept over the last 20 years. And we've only really been seeing literature in this small space of the last 20 years. This gained particular attention in 2015 when Google published results of its Aristotle project. This was a big initiative by Google to understand what were the things about the teams that made them the most high functioning. And so Google studied 250 attributes of 180 teams and found that the teams that were the highest performing was not based on their background, their experience, or their education, but on psychological safety. And there's extensive literature that has backed this up to show that teams with psychological safety perform the highest and are the most innovative. This has become increasingly more relevant since we've moved away from siloed jobs to these collaborative team-based work environments in really complex, uncertain, and risky situations. To be successful, you can't just be smart, you can't just be motivated, you need to be able to speak up and share ideas, and teams need to be able to do this. Now, I know that this makes sense, we can all agree with this, and yet there are plenty of examples inside and outside of healthcare where the lack of psychological safety has had catastrophic events. We often cite the airline industry as sort of the shining example of a high reliability organization, but it wasn't always that way. In 1977, the airline industry experienced the deadliest crash in aviation history with 583 casualties due in part to a lack of psychological safety. Dubbed the Tenerife disaster based on the location where it occurred in the Canary Islands, this airline disaster occurred when one of the jets mistakenly thought they had been given the all clear, took off, and crashed into another Boeing 747 jet on the runway. Now, there were multiple issues at play that day. The airport was really crowded. There were extra planes there because another airport had to divert its air traffic there. It was really foggy, so there wasn't great visibility. There were communication issues with air traffic control. There wasn't a standardized language at that time that was used. But in addition to all of that, the pilots within that plane did not have psychological safety. There were two junior pilots who did not think that they were all clear and were concerned. But the captain of that flight was one of the most celebrated pilots in their airline's history. He was actually featured on a magazine spread or an ad spread just a little bit prior to this. And so they didn't feel like they could speak up. They tried, they were shut down, and then they stopped. And so that lack of psychological safety, that hierarchy, prevented them from speaking up with disastrous complications. In 2003, the lack of psychological safety led to another well-known catastrophic event at NASA with Columbia, when the spaceship Columbia experienced a catastrophic re-entry into Earth's atmosphere, killing 7 astronauts. In this case, one of the engineers who was involved thought that he had seen something occur on the launch. He thought that there was a piece of foam that might have broken off and damaged one of the aircraft's wings. He wanted to get satellite pictures to look at this further. He wasn't really sure, but he was concerned. And so he approached his supervisor and he got shut down. And he talked a little bit with people around him about his concerns, but he sort of got shut down again. And so on subsequent meetings, he didn't speak up. And he was right with catastrophic results. And then more recently, some people might remember the VW scandal, deemed Dieselgate, which is really interesting to me because I had one of these cars. But the engineers at VW were tasked by upper management, by their bosses, to design an engine that was high speed, highly efficient, and also was clean, that would pass the strict environmental regulations in the United States. And they couldn't do it. They couldn't meet all of the requirements that they were told to do. They were afraid to speak up. The culture there was really toxic. It was not psychologically safe. And so this group of engineers did a workaround. I'm not techie, so don't ask me exactly how it worked, but they designed software in the engines that would know when the engine was being tested for emissions and would not operate to its full functionality. And so for 10 years, these cars were on the road. They were cheating this emissions process. And it wasn't until a university was looking into sort of diesel engines globally that this came to be. And it was because those engineers did not feel psychologically safe. They were afraid to lose their jobs if they failed. Fear and intimidation created these conditions that led to Dieselgate. Next slide, please. So why is it so hard to speak up? As an individual, it feels sometimes easier to stay silent. We heard that before. Staying silent means that you feel, at least, like nobody will think that you're dumb for asking a question, or incompetent for admitting a mistake, or that you're an obstructionist or not a team player for dissenting. We all want to look good. We all want to control sort of the narrative of what people think of us and people's perception of us. And so it feels like staying silent is safe. It keeps us safe. We can play it safe and nobody will think poorly of us. Silence benefits the individual, but it doesn't benefit the organization. And it most certainly never benefits the patient. And the truth is that the stakes are too high to be silent. As we know, sometimes we're talking about life or death situations. And so we need to create a culture where we can speak up even when it feels hard. So how do we do this? First, we have to understand this is our collective responsibility. No matter who we are in the organization, we are all in this together, and it's all of our responsibility to contribute toward this culture. We are all here aligned around the same goal, excellence in patient care. And so being intentional in the way that we support one another and being intentional in our teamwork and collaboration is key. I've included a few slides about practical tips and tricks for developing this type of culture. First and foremost, we can welcome others' viewpoints and solicit diverse opinions. As part of this, we have to ask for and be receptive to feedback. I personally love this quote, "What am I missing?" I use this a lot. I use it when I'm developing a new protocol or a new project, and I use it clinically. I think "what am I missing" opens up the conversation for other people to step in and ask offer alternative opinions or ideas. And then when other people do speak up and offer a dissenting opinion, we should meet that with gratitude. Didn't think about it that way. Thank you so much for bringing that up. And for those who solicit feedback more formally from people, thinking about ways to do it in different ways, whether you're offering in-person feedback, also email, also polls. That way people can feel comfortable to be candid in a way and a forum that feels safe to them. We also have to be willing to be vulnerable. We have to take off the mask of our own perfectionism. I love this quote. I don't have a great answer for that right now. So we're gonna look into that. I'm not sure. Acknowledge when you don't have the answer. Sometimes sharing how you're feeling can be really helpful. And then acknowledge that we're humans too, and we're all humans. Take a break if you need it, and really allow yourself to be vulnerable. Listening to understand is also so important. We all, when we listen, sometimes we're thinking about how we're going to reply, what we're going to say. But it's important that we develop the discipline to not prepare that response in advance, to be truly intentionally listening, to eliminate distractions, to be curious about what other people have to say, to loop back, check understanding, and then to dive deeper. I love this quote. Tell me more. Tell me more. You're not agreeing or disagreeing. You're just diving in deeper to another's viewpoint. We also need to be able to manage our emotions. It can feel really uncomfortable to have someone else challenge your opinion, but understanding that it's grounded in deep care for the patients we serve can help mitigate some of those feelings of discomfort. We all see things from a different lens. Everybody has a different role, a different perspective, and a dissenting opinion does not mean that you're not good at your job, that you're not competent, that you're not hardworking, that you're not well-intentioned. It just means there's another angle to consider, and we should be grateful to hear that other angle. And then finally, embracing failure, shifting our mindset to recognize failure is going to happen. We can learn from it. We're not always going to get it right on the first try. We know that. But extracting learnings and focusing on continuous learning will be really important. Now, I recognize that can be really, really hard to speak up, especially as sort of new to practice, our new interns, our new residents, we've heard that, our new nurses. But no matter who you are, no matter what your role is, whether you're brand new, you're really senior, that can feel intimidating. But it does get easier the more that you do it. And there are some tips and tricks that can make it a little bit easier. Next slide. So if you have points you want to talk about, you can prepare them ahead of time, rehearse them, lay them out so you know what you want to talk about. Start small. Start small. It'll feel good and you'll be able to build up. Focus on your message and not how others may perceive you. Remind yourself of the value of the contribution you're bringing to the conversation or the situation. I statements have been found to be very helpful. I feel, I believe. They allow you to take ownership. They ground it in your perspective. They don't come across as accusatory. They really prime the listener to hear what you're going to say. Be assertive and not aggressive, and understand sometimes speaking up doesn't get the desired outcome you have, but that's okay. You need to still speak up. Here at HUP, we have a fantastic framework that we've learned about called the CUS framework that can make it easier for us to speak up. It gives us a common language to voice our concerns in a way that's respectful, but clearly and firmly addresses our concerns. Next slide, please. When using the CUS framework, state your concern, state why you're uncomfortable, and if the conflict is not resolved, why there's a safety issue. If something doesn't feel right to you, it's important to raise concerns, especially when it comes to patient safety. We truly want to call out these problems in a way that's respectful, and this framework gives us the tools to do that. And final slide. Truly, we are all responsible and capable of creating an environment that can be psychologically safe. We deserve it, and our patients deserve it. We know that there's extensive evidence that shows that teams that are psychologically safe perform much better, and it allows us to fully show up for our patients, for their care and their healing. By using the CUS framework, centering on the patient, we can all speak up and help to foster psychological safety. Thank you so much. I'm going to hand it back over to Steve.
Great. And I know we're over time. We had some technical issues throughout this, but I just want to thank everybody for their presentation today and our panel discussion, to where everybody made themselves vulnerable and sharing their stories. And I think you heard that come up surrounding how do we create a psychological safe environment. And our hope with this presentation was to show that these conversations are important to have. We need to understand different people's positions and interests, how we move this forward to really improve our culture on our journey to high reliability. And we do see that escalation of care concerns are built into our daily work. And it doesn't just center around one team role or department. And I want to comment, we do have amazing structures here in place that are meant to be supportive. We do a good job at calling rapid responses, our clinical emergencies team to do that, but continuing to optimize how we move that forward and hearing how everybody, different things are debriefing on them or understanding. So we really do an amazing job. And remember, it's not a reflection on just one individual doing their job, but how we support each other moving it forward. And always to remember, assume positive intent. We always come in here to do the best things when we want to escalate these concerns or someone escalates it to you. So really kind of piggybacking off what Julie said. And even though one person or role may be feeling comfortable in a situation, remember that might not be how everybody feels. So please be curious and ask why they're not feeling comfortable. So I, again, want to thank everybody for the amazing presentation today. Thank everybody on the line who came to listen. These conversations are important. This is what we're trying to achieve with our quality and safety grand rounds, to really open those dialogues, continue on our journey to high reliability, and provide this type of content to everybody. So again, I just want to thank everyone involved in the presentation, the panelists, Julie, just thank you. And I hope everybody has a great day and take care.